Good evening, everyone. Thanks for coming. Lynn Singer, who you're probably here to see today, is Deputy Provost and VP for Academic Programs at CASE. She's also a professor of pediatrics and general medical sciences in the School of Medicine. She's a pediatric psychologist and has edited 2 books, one on the assessment of the infant and one on adolescence. And besides what she's going to speak about today, she's also been studying the effects of methylene dioxymethamphetamine, otherwise known as ecstasy, on the fetal infant. She's been affiliated with CASE since she was a graduate student, and she has fond memories of Mather Memorial. So please welcome Lynn Singer.
Thank you. Thank you, Anita. And it's a pleasure to be here. Can everybody hear me with this? All right, terrific. And if I can just do, the pointer is the red thing?
No, it's the
right thing, okay. And
the pointer is the red.
That's what I thought. I'm going to first give you some context today. The field that I work in with the cocaine studies is called behavioral teratology. And so I want to give you a brief understanding of what behavioral teratology is and some of the principles related to it. Then I'm going to give you a little bit of a history of cocaine use in this country, and then present you with the data from our funded study from the National Institutes of Health that's been funded now for about 12 years, 13 years, to look at cocaine-exposed infants and their development. And today we'll talk mostly about cognitive development, and I'll try to have not too many of those data slides. But anyway, I am a clinical psychologist, developmental psychologist, and behavioral teratology is really the study of outcomes, neurobehavioral outcomes that may result from toxic exposures to a fetus. You have probably heard somewhere in the background, we first became aware of issues of teratology in general with pregnant women getting rubella. And if you're a pregnant woman and you get measles or rubella, you're likely to have a child with sensory deficits such as hearing deficits, and that was well known in the 1940s. But teratology really became well known because of thalidomide. And that is, teratology, the word comes from the Greek word for monster. And generally we think about specific malformations that are caused by a toxic exposure, such as happened with thalidomide. At one point, we believed, and because of our belief system, we didn't think that anything could cross the placenta and hurt the fetus. So when babies began being born with thalidomide exposure, or we didn't realize it at the time, with these kinds of malformations that are called phocomelia, we didn't understand exactly what happened. After the studies began, it became totally understood that the developing fetus could be particularly susceptible to toxic agents that might not even harm or affect an adult. And that was the case with thalidomide. If adults took it, there was no harm related to it. But for infants, for fetuses, it was highly toxic. So thalidomide was sold from 1957 to 1961 in 50 countries to combat morning sickness in pregnant women. 10,000 children were born with phocomelia over those years. In this country, the FDA would not approve the drug because of a very brave woman named Frances Kelsey, who remembered studies that she had in her background in which she saw that there were things that could cross the placenta at the time, which most doctors didn't believe could occur. One of the things I want to bring out to you is how difficult it may often be, even in a case like this where clearly something has caused this kind of malformation, to understand what kind of an effect some prenatal exposure might have on fetal development. For thalidomide, the limits of danger were extremely narrow. You only needed to take 1 tablet if you were a pregnant woman between the 20th and 36th day after conception to have a negative outcome such as this. So understanding and making the connection between a fetal exposure and an outcome. My point is that it's very, very difficult, even in cases like this. At the time, 2.5 million tablets were actually distributed in the United States, despite the fact that there was no approval from the FDA, because it was considered an experimental drug and doctors were allowed to give it out. So the field that I am in, which is a branch of teratology, is called behavioral teratology. And when we think of that, we're thinking about the psychological damage that can occur with a prenatal exposure. And Chip Voorhees from the University of Cincinnati is kind of the father of behavioral teratology. He wrote the original textbook in the 80s. And has been quoted as saying that the psychological damage of toxic exposures prenatally has been underexamined and underemphasized, and that often these are the most serious and prevalent of the defects present. So this field benefited a great deal by its timing. In the 1970s, we had this exposure to thinking about the environmental effects, changes that had occurred in our environment. And if you think about it, hundreds and thousands and millions of different kinds of chemicals have now been poured into the environment in various ways, hormones in our meat and all those kinds of things, in great quantities, in ways that we really don't understand their effects on the fetus and child development, even with early exposures. So toxicology became really very scientific during the 1970s. We had animal studies that started demonstrating the effects of things like vitamin A. The reason you can't take Accutane when you're pregnant is because it causes birth defects. Salicylates and PKU and the kinds of these exposures and their effects on fetal and infant development became apparent. When we think about teratology and behavioral teratology, we think about these critical periods when the fetus might be vulnerable to insult. And so you've probably heard some of this before, but we think generally about the pre-implantation stage, the first trimester in which the organs are formed, the second trimester in which we think about tissue formation, and then finally in the third trimester, the functional organization of the brain occurs. And we know that that's dependent on lots of neurotransmitter systems, and there's a greater understanding now of how the brain is developing in the fetus, especially accelerated in the third trimester and afterwards. So to give you, in this slide, I'd like you to just think about teratology and behavioral teratology. When we think about the dosage of a toxin as well as the percentage of the fetuses that might be affected. And you can have something highly, highly toxic that actually causes fetal death in either small or large amounts, going up to a lower dose that might cause a malformation, as you saw in thalidomide, or something that may cause growth retardation, which I'll show you later. And way over here is that at low doses of a toxin, there might be functional disabilities that could occur, what we're thinking of, learning disabilities, autism, reading problems, lower IQ, that may occur even when you have an absence of actual physical defects. So some of this is a little simplistic because a lot of these things occur together, and the functional defects could be quite severe in the absence even of any kind of physical impact. Often we see things with growth retardation early on that are kind of a precursor or give us an idea that there may be deficits in the child. Okay. We talked about rubella in the terms of the historical perspective. We talked about the 1950s when thalidomide occurred, and we began to understand the devastating effects that could happen with toxins. We began to understand the next phase was the developmental neurotoxicity of methylmercury, which first became apparent in Japan. In the 1950s, fishermen and their families in the small fishing village of Minamata began to suffer a disabling neurological disease that eventually was confirmed as methylmercury poisoning that had occurred in their waters. There was a higher incidence of cerebral palsy that occurred at that time, and it looked like it was related to the exposure to methylmercury. And of course, there were adult consequences, but they were not as devastating as they were to the children who were born. So it seemed to be a fact that the damage inflicted prenatally was actually much worse than that on the adult. Without markers of the exposure, however, they could not determine that this was actually related to methylmercury. However, later, in 1971 and 72 in Iraq, there were 80,000 tons of seed that were exposed to methylmercury. The methylmercury, because this seed was to be for planting only. And what happened was people used it for baking accidentally without thinking about it. The children of the women who had consumed the treated wheat during pregnancy exhibited the same signs of cerebral palsy and neurological damage and severe delays that had occurred in Minamata. So that really confirmed our understanding and helped us notice the fact that methylmercury was a toxin as well. The next one to think about, and you probably are very aware of it, and it's going to come up in our study today because it's popped up in our data, is lead. Lead is an ancient metal, and this is a picture of a window that's where the paint is scraped, and which is the way most of our children, poor children especially, are currently exposed to lead. We've recognized from ancient times that lead could cause death and all kinds of other problems. However, we did not realize or recognize its neurodevelopmental toxicity until the late 70s, when studies began to look at the teeth and the amount of lead in teeth and relate that to children's development. And we actually now have data that's been more and more refined over the last 5 years, which indicate that even at lower levels, below 10, these low exposures to lead can have negative effects on children's development. So what we're finding out is that the major problems become obvious through major outcomes that are affected, but that at lower levels, things like learning disabilities or deficits in reading and IQ can be now reliably connected to these kinds of exposures. Okay. So, lead screening programs began in the 1960s and the 1980s, and beyond, we have been looking at lead levels and the cognitive deficits that are associated with those levels. The next one I want to bring to your attention because it also fits in with what we're thinking about, and the next big, I think, advance in understanding that we're really looking at now is fetal alcohol syndrome. And this is a classic picture of the features of a child with fetal alcohol syndrome. 1973 was the year when this syndrome was really discovered or named in a way and has been studied extensively in the last 30 years since. The psychological effects involve mild to moderate mental retardation, abnormal reflexes, irritability in infancy, hyperactivity, and in some cases, learning disability in adulthood. What we're finding is that we have this syndrome of minor facial dysmorphology. These children are not born without limbs, but we do have facial features that are detectable that seem to fit into a syndrome, growth deficiency, and often mental retardation. And even though many children are not mentally retarded, they are really lower in the IQ range because of exposure to alcohol. This is the first child identified, and the group that has identified him has followed a small group of these children now. They're now in their 20s, and they're now doing MRI studies looking at the brain, which sections of the brain have been affected through this exposure to high doses of alcohol. And you can see the classic features, and you can see that there are differences in the physiology of this person. This is just a slide that shows you that it's even without frank exposure to heavy doses of alcohol, we now have many studies that demonstrate that at lower doses, you can show differences. You can see the percentage of scores that are, the range of scores that are above in terms of IQ. The mean is 92 in this sample for mothers of the children of mothers who never drank during pregnancy. While there's really a dose-response relationship to the amount of alcohol consumed and the IQ, even though they're all within normal ranges. And a number of studies have confirmed this, even looking at breast milk and exposure to alcohol in breast milk. Another big one that you probably have heard about that pregnant women or women who might get pregnant that we think about today are the PCBs. This exposure, the Jacobsons at Wayne State came down. Actually, Joe Fagan and I trained them in the Fagan test, which they used to look at women in Michigan who had eaten fish, and they measured the level of PCBs in these women's breast milk, as well as got dietary histories of them, and have now followed those children up for 12, I guess they're in their teens now, but have demonstrated that there are subtle cognitive and attentional deficits associated with exposure, which has led to the warnings for women now not to eat fish because of the exposures to PCBs as well as to mercury. Okay, just to show you some other thought, these are very recent. I was on a panel 2 years ago to look at fluoxetine. Here's a drug that is prescribed for women who are depressed, and we are now identifying what's been called a serotonin reuptake inhibitor syndrome in infants. There are not many studies done, but there's enough out there in the animal literature and in the human literature to suggest that we really need to be thinking about the effects of these drugs. And I guess one of my points is to demonstrate to you that there are so many drugs out there that we know very little about. Even if they are acceptable for adult use, they may have effects on the fetus that won't be known for a while, so that we have to be very, very careful about them. Okay, one last one, long-chain polyunsaturated fatty acids. We don't need to think also just about exposures. Exposures to various substances can have negative effects, as we've shown, but also positive effects. And LC-PUFAs are these long-chain polyunsaturated fatty acids, AHA and DHA, that are found in breast milk, but they were not in formula, infant formula. There had to be studies done about whether or not putting these things in infant formula would affect infants. And actually, there are data that suggest that by putting them in formula, we can actually improve vision in very small preterm infants. So there are benefits to be thought about as well as to think about deficiencies. You're probably very aware of the folic acid deficiency that has occurred and that was shown to be a cause of myelomeningocele, spina bifida, which we've reduced the incidence of spina bifida in this country by adding folic acid to all the breads. So you've got to think of it both ways. There may be deficiencies that can affect, and there can be positive effects of different substances as well. And this is just to show you, out of those studies, they're now marketing these DHA and AHA, and I actually read a study that said that if you took DHA, if you had enough DHA in you, you might not get Alzheimer's, you might not be as likely to get Alzheimer's. That was in the New York Times this week. But in this case, they're marketing the formula that has these substances in them, saying that it will help the baby's eyes. And there is some evidence that these substances are necessary for good vision. So we've gone through the historical context. I just want to point out now that our studies relate specifically in the 1990s. There became a great deal of interest in this country on drugs of abuse, specifically cocaine. And we're one of the studies that were funded at that time. There are also 2 marijuana studies that have been funded, one in Pittsburgh and one in Ottawa. And those children are growing up, and we're beginning to find out some of the effects of these drugs on children. One of the interesting things about marijuana and heroin is that many of these studies were begun in the pre-Reagan era and then were stopped after a couple of years, because during the Reagan era there was kind of a ban on studying these drugs because it looked like we were approving of them by studying them. This is the study. It's been going on for, since 1994 and before, and there are many, many faculty on this campus and students who have gone on to get degrees. For example, Teresa Linares now has her PhD. This is an outdated slide. But Bob Arendt, who's now at Ohio State, Betsy Short, who's in the psychology department, Barb Lewis, Nancy Klein and Sandy Russ, as well as Les Kirkner, have all been very, very involved faculty in these studies. And this is the kind of study that you can't really do without lots and lots of people working in their areas of expertise. I want to show you this picture, which some of you may recognize. It's called Gin Lane. The artist did another one called Beer Lane, and it addressed an 18th century problem in England, which was abuse of spirits by the working class. Here you can see a mother who's drunk on alcohol, not abandoning her baby. And I think this picture shows you, in terms of various drugs of abuse like alcohol and cocaine, that often there are very severe social conditions that are attached to the kinds of behaviors that occur in parenting that we also need to think about. Actually, this was quite a significant picture. After this picture was released or made, the Parliament in England passed the Gin Act, which regulated the sale of alcohol. What I want to show you next is a picture that was in the New York Times that's in London. It was in our New York Times, but it comes from London, called Cocaine Lane. And this picture is kind of a parallel to the alcohol picture in terms of what has occurred with drugs of abuse and the effects that they may have socially, not thinking necessarily of them as a toxic substance for the fetus, but just what it does to the behavior and the social fabric of the community. And that is what occurred here. And now, when we started our study, there were very few concerns about cocaine in England, but right now they're very concerned because they have 10% of their 15 to 35-year-olds who are using cocaine or have admit to having used cocaine. And there's a lot of crime, just as we had during our cocaine epidemic occurring there. This was the kind of headline that precipitated the government funding our study, as well as other studies that I've showed you on cocaine in the 90s. And I like this: crack babies turn 5 and schools brace. Drug-addicted toddlers are raising havoc here. These are very alarmist. I have this image of these 2-year-olds like running en masse through the schools, which is kind of silly. But if you recall, the New York Times did a series of articles. Many people were very alarmed. It was very unscientific. There was a small report of a group of babies born with exposure to cocaine with abnormalities. And there were all kinds of articles saying that these children had no conscience, that they were going to grow up to be monsters, that they could never make emotional connections. And it was very scary, but without any basis in fact. So these were very alarming reports. One thing you should know is that this is America's second major cocaine epidemic. In 1900, about 250,000 Americans in a population of 7 million were opiate addicts. That's about 1 in 300. And in 1902, it's estimated that there were about 200,000, or about 1 American in 375 who were cocaine addicts. So in early 1900, about 1 in 200 Americans was a drug addict. And one of the things we want to think about when we think about cocaine is that it was a very widely promoted substance at the time in the late 1800s. Sigmund Freud, one of the fathers of psychology, experimented extensively with cocaine. And in fact, he wrote a song of praise to what he called, quote, "this magical substance which wards off hunger, sleep, and fatigue and steals one's intellectual effort." And actually, I think that's a good description of what cocaine does for you as an adult if you take it. There are many positive effects to the drug, and he actually became very involved with it. And there's some books written that say that his whole theory of psychoanalysis came out of his cocaine addiction. But he was thinking about it as an addiction, as a cure for heroin addiction, which was opium addiction, which was quite prominent at the time, one of his friends. He promoted the use of cocaine for curing opium and narcotic addictions. Other proponents included the Pope at the time, Sarah Bernhardt, Thomas Edison, etc. Interestingly, in contrast to today's times, the drug addicts of that time period were the so-called genteel ladies, and they were the typical drug addicts of the times. They were given the drug by their doctors for their feminine ills. You may be aware of Long Day's Journey into Night. I mean, that is the story of the playwright's mother's opium addiction. So in this drawing, which came out of one of the popular magazines, the woman on the left is saying that she became, quote, habituated, no, I mean on, yeah, the right, that she became habituated when the doctor provided a stock of morphine to ease pain from muscular rheumatism. And so we had, I often wonder, you know, what were the effects when we had absolutely no idea that drugs may have an effect on the fetus? What were the effects on babies born at that time? We have absolutely no knowledge. By the turn of the century, opium dens were a fixture in many American communities and much patronized by what was called the sporting classes. Here's a group of, quote, swells visiting a den in New York City's Chinatown. And I think if you look at movies that are time-related, you can see in Europe and many other movies where these opium dens were quite common. Cocaine products were commercially available, and at that time there was no regulation of drugs, so you could get any drug over the counter. Some of the first commercial products using cocaine were the coca wines, and one of the most famous was this one called the French Vin Mariani. It typically featured testimonials from the Pope and kings and artists. Here, in this one, a Czech artist designed a postcard declaring that, quote, the mummies themselves stand up and walk after drinking Vin Mariani, and I'll bet they did. The next one, which you're probably very aware of historically, is that Coca-Cola was just one of the dozens of beverages that were promoted by ladies who wanted to get rid of the demon alcohol. It was considered a temperance beverage. So there were others were Gluca-Cola, Coca-Nola, Dopa-Cola. In 1903, Coca-Cola removed cocaine as an ingredient as people became aware of the negative effects of the drug, and the drug fell into disrepute. Until 1903, there were 60 milligrams of cocaine in every glass, so it was quite a dose, and it's still flavored with coca leaves, but not with the drug. Other manufactured items were cocaine tooth drops. I mean, children were taking these things. They were quite popular at the time. Cough medicines, etc. There are also what was called the CATARRHAL powders, which were snuffed to relieve a variety of nasal congestions, and they contained 2 to 5% pure cocaine. This one was called Dr. BIRNEY'S, and Dr. Gray's were the most popular, and they were known as Bernie blowers or gray men, and it became quite apparent that they caused problems in people. But it's very interesting looking at this. People are told that this remedy contains 2.5% cocaine and is prepared from a prescription of one of the foremost nose and throat specialists. And these were just over-the-counter drugs that people took. In 1912, the estimate was that about 5,000 deaths occurred from cocaine use, and that's when the population of the United States was a third of what it is now. I like to use this slide because one of my points is that drugs are neither good nor bad in and of themselves, and we don't know what their effects will be till we study them. And here's Bayer, which around the same time as this ad came out, was well known for its aspirin. It introduced a new over-the-counter drug called heroin, and it was touted as being highly effective for quieting coughs. And it was also touted as being non-addictive, which is one of the things I think to think about in terms of all substances, that often they're promoted as being safe, and it really takes quite a while and a long time to understand what the effects might be. But here we have two drugs, one which has been one of the most benign, most helpful drugs probably ever developed, and the other which is truly a scourge and is actually coming back now in its smokable form. So it's becoming a new problem, and we may be needing to study that drug and its effects on anyone who gets pregnant. I don't know what happened here. I wanted to go back to this slide just to remind you of where we started. In the 1990s rather, the government became very concerned, and there was this push. So they funded all these studies. We were one of them. We know that cocaine, it became quite apparent, especially in the inner cities, that cocaine was a bad drug in terms of crime, in terms of its effects on adults. We know that it causes tachycardia, it has major effects on the central nervous system and the heart system, so that became fairly obvious to people. What we did have originally was a huge because of a number of factors, including the fact that women were now using drugs. This was not like heroin, which was injected and which was not appealing to women, but women had learned to smoke in this country after World War II. And so moving on to drugs like marijuana and then cocaine, which was manufactured in its smokable form, became very easy. If you recall, cocaine was a very expensive drug, and I remember going to New York in the 1980s and meeting these lawyers, and they all had these stashes of cocaine in their desks, and it became kind of a, Michael J. Fox and all of those people from the 1980s. Cocaine was very expensive and only used at that time by lawyers and doctors and people who had a lot of money. However, the Medellin cartel saw an opportunity, and it's really interesting to me to think about the manufacturing of this drug. They created a Walmart for themselves in which the smokable form called crack was very cheap, and it was marketed through the inner cities with a lot of crime, etc. The negative effects became so apparent to people immediately that really the epidemic subsided after about a 10-year period because people who were educated and had other opportunities really stayed off of crack cocaine. It's a highly addictive drug, and it became really a scourge of the inner city, and particularly of people who were not able to think their way through what the drug might do. And those are the kinds of people who we recruited into our study because they really became victims of this drug. We know cocaine has 3 mechanisms of action. It impairs the reuptake of norepinephrine and epinephrine. What happens is that your brain recycles these neurotransmitters, and cocaine prevents your brain from recycling them so that it floods the brain with these feelings. The norepinephrine mechanism creates the problems of hypertension, tachycardia, and vasoconstriction, and you probably have heard about the people who, may have heart problems undetected, but with a cocaine dose, it may cause them to die. It also impairs the reuptake of dopamine, which is one of the reasons it's so euphoric and reinforcing. Also impairs the reuptake of tryptophan and serotonin, which is why it affects the sleep-wake cycle. And that also enhances the dopamine effects. One of the things I want to say, especially to all the students here, because every time I say this, people don't realize it, cocaine has its most profound and reinforcing and addictive effects through its smokable form of crack, even more so than when injected. And that's because it goes directly from the lungs to the brain. So that is it gives you the quickest, fastest, highest high that lasts the shortest amount of time. As opposed to when Indians used coca leaves, they became addicted as well, but when the coca leaf goes through your GI system, it takes a lot longer, it's not as reinforcing, it's weakened somewhat, and it has a different kind of effect. So crack cocaine is particularly, anything that's smoked has a particularly strong component to it. The potential mechanisms, why do we know how cocaine affects adults? Why do we think it might affect babies, the fetuses? We know, number one, that it has there are direct cocaine effects on the fetal brain. We know also that it can affect the baby's brain through hypoxia. The mother's, it causes blood pressure to go up, it constricts the blood vessels, the fetus does not get as much nutrition, it doesn't get as much oxygen, and we think that's one of the reasons that these babies are born small. And we also know that these neurotransmitters that are affected by cocaine are very important for brain development in the 3rd trimester. So that's all involved in the reorganization and the organization of the brain during that 3rd trimester, and you're taking exactly those neurotransmitters and you're playing with them. So this is just a slide that kind of shows you the difference in the rush with the Indians and the coca leaves. It lasts a couple of hours, it's low reinforcing as compared to crack, where you get the high in less than a minute, it lasts for a short amount of time, and then it increases, you have a high need to go back and get more of the drug. This is a broad model of what we think about when we do a study like this. Our study is a study of the developmental effects of cocaine on child development. And when you think about any toxin having effect on a fetus, you think about a number of things, and one is the genetic component. There's a context in which that, we're not going to talk about that today because we don't have any data on it, but there's increasing interest in looking at the genetic interaction. That is, something in your genetic nature may make you or your fetus more susceptible to a drug's effects than someone else. And we know with alcohol now that there are many genetic interactions that occur. Think about nicotine. There have been studies that demonstrate that for many people, nicotine is not that addictive. It wasn't for me. I tried to smoke when I was in college and I just didn't like it. And probably it's because I'm lacking in a genetic piece that makes that processing of the drug more easily done, which gives other people a really good feeling. And so we all have a genetic makeup that also affects this, and we won't be talking about that today. But in addition to the genetics, one of the things we were very conscious of when we developed these studies, all of the scientists in the country, was the fact that the environment, children's cognitive development, apart from any fetal exposure, is heavily affected by the parental environment, the school environment, violence. We know that there are all these things that are related. For example, maternal education, family income, exposure to violence, the mother's psychological status, depression, etc. Whether or not a child is placed in another home, is adopted or put in foster care, whatever the social supports are. All these kinds of things also are known to be related, independent of any drug exposure. So what we try to do is control for those other factors when we look at what are the possible toxic effects of the drug itself. One of the things that's hard is that, and as you may have heard, many people when these studies first came out said, oh, it's really just that these are poor kids, they're in the inner city, their parents are poor and they're not really getting what they need, and that's all it is, it's just poverty. So you have to try to piece out those things. We also know that there are biologic issues as well. There are other drug exposures, as you'll see, that occur. Almost no baby, we couldn't find one baby that was exposed only to cocaine. There are other factors that we know affect birth outcomes and children's outcomes, like prematurity. I have a whole other study which is just on prematurity that looks at those factors. Things like low birth weight. And we know all of these things affect the way the parent and child interact. And then in the end, we have various kinds of outcome domains. Something that might affect speech and language might not affect emotional behavioral development or might only affect motor development. So we have to look at those outcome domains separately. We looked, how do you measure cocaine? That was also a factor. Nobody's going to tell you that they use cocaine during pregnancy. Or if they do tell you, we know from the alcohol studies that people tend to deny and minimize their alcohol use because they know they're not supposed to do it. We also benefited from some of the research that was done before us, which suggested that you could look for cocaine metabolites in the infant's meconium, which is the infant's first bowel movement when it's born. Over the last two trimesters, an accumulation of waste builds up in layers. And we took that and they took it and mixed it up and put it in the lab, and we looked at these cocaine metabolites. So one thing we were interested in is how well could we detect through interview as well as through the meconium. We found that actually with the women that we involved in our study who had already been screened by the hospital, that we had a fairly high rate of just by interview finding out who was cocaine exposed or not, which babies were exposed. You can see only 9 mothers told us they weren't using, whom we could identify by meconium were actually using. However, where we found something that really helped us with the meconium was that we were able to look at the concentration of metabolites. So we could say one baby had a lot of cocaine metabolites, whereas another had a low amount. And we looked at whether a mother told us that she used a smaller amount or a larger amount, or whether they were light or heavy users of cocaine during pregnancy. And that's where we found that the meconium really helped us. When we looked at mothers who were actually light users, it was consistent with the meconium. We found out that there were actually 52 mothers who, by interview, said they were light users, but we found out that they were heavy users. So that made a real difference in the way we could classify the babies and the way we could look at the dose response effect. This is the design of the study. We had two groups. One were cocaine exposed, the other were non-exposed. We've been following. We followed them now from birth on through 9 years. The data I'm going to report on today are through 9 years, and we're seeing them now at 10 years. And Dr. Sonia Minnis has taken over this grant, and she'll be following them to 11 and 12 years of age. So our definition of exposure was that you had to be positive. You could be positive on anything. If the mother said she used, if her urine was positive, anything that said she was positive, she was positive. And if there was, you had to be negative in all of the drug screens in order to be put into the non-exposed group. And you can see why this is. If I'm looking to see for the bad effects of cocaine, and I have a lot of mothers who told me they didn't use, and they're in the control group, I put them in the control group, but they did use, I'm not going to find any differences because they're going to be the same mothers. So it's really, really important that we try to find out as much as we can and differentiate that this baby did not have any exposure. These are the covariates, and they relate to some of the things I showed you in our model. All of the kinds of things that we needed to account for with the baby and the mother. We need to know about the mother's age, because we know that that correlates with various kinds of outcomes. If you're over 30, you may have more problems in your birth than others. Mother's race, how many children she had had, how many prenatal care visits, which correlates heavily with how the baby, with whatever the infant's problems are. Years of education, because that's going to be a direct correlate of the child's cognitive development. We know that from numerous studies. How much did the mother use other drugs? Whether or not she was married, what was the social class status? We took also the mother's vocabulary. We gave her nonverbal IQ tests. We also did a symptom inventory, which looked at how depressed or how hostile or how anxious the mother was. And we also did this because we found that a lot of our babies, a number of our babies who were cocaine exposed, were placed in foster or adoptive care homes. We also did this with the caregiver. So all along the way, at every visit, we looked at both the biological mother. If the biological mother was no longer the caregiver, we got the data on the caregiver. And this turned out to be very, very important, and you'll see why. If you look at our cocaine group versus our non-cocaine group, and this is true of all of the studies throughout the country of cocaine, no matter how well you try to match them and just take mothers, kind of from the same clinic who are using cocaine or not using cocaine, there seem to be differences. Cocaine-using women were older. They had had more children. They had had fewer prenatal visits. They weren't getting prenatal care. Look at the IQ scores. The Peabody is the vocabulary score, but they had lower vocabulary scores. And these are quite low to begin with. 100 is the average for the population, so we're talking 78 and 74. The nonverbal scores also look at the Global Severity Index, which is the index of psychological problems. The cocaine-using women, and this is true of all studies of alcohol and drug-using women, especially women during pregnancy, where you know that you're not supposed to use any of these drugs, they have twice the rate. About 50% of them have some other significant psychological disorder, primarily depression, paranoia, anxiety disorders. So, and we also do a measurement of the home environment. How stimulating is the home? Because we know that that correlates heavily with the child's outcome. So we controlled for all of those factors. The most important thing, as I said before, there aren't too many drugs that you can find in isolation. Even if you took tobacco or alcohol, most people who are using alcohol are also using tobacco. When we look at cocaine-using women, they're using high rates. 81% also used alcohol during pregnancy. But our control group, 65% used alcohol. 50% used marijuana, 88% tobacco. We virtually could find no one, and we couldn't find anyone who didn't use another drug. And I don't know if it's on here, it's not on these slides, but they didn't just use more drugs. They use more of drugs. They use twice as much marijuana as the mothers in the control group. And the reason for this is that cocaine is one of those drugs that people use alcohol and they use marijuana to either prolong the high or to reduce them coming down from a crash. Some of that is true with MDMA as well. We did a study at Case of ecstasy use, and we found that the students were also using alcohol and marijuana, especially marijuana in high amounts. And that's because cocaine is a stimulant drug. And so when you stop the binge or stop using the drug, there's kind of a down that occurs. These are just, okay, so here are our findings. In terms of birth outcome, we found that there were specific effects of cocaine, alcohol, cigarettes, and the mother's psychological distress related to poor, this should be birth weight actually, lower birth weight. So all of the drugs show up there. We found that cocaine decreased the child's head circumference, and that's after we controlled for all the other factors that I showed you before, as well as did mother's psychological distress, which I think is very interesting. One of my hypotheses that I would love to look at in terms of genetics is we know that depression and these kinds of psychological disorders have a heavy genetic component. And are those mothers who may be positive for some of the genes for depression, et cetera, are their children likely to have more effects when combined with other drugs than do those who just have distress alone? We also found a negative effect on birth length from cocaine, alcohol, and marijuana. So if we're looking where are there cocaine effects, there's certainly cocaine effects, and the alcohol and marijuana effects have also been found in other studies where they've just looked at alcohol and marijuana. And what you want to think about with these drugs is when we say how much of an effect, they're additive. It's if you only had the cocaine effect, it would cause a certain decrease in the birth weight. But when you add alcohol exposure and the dose of alcohol exposure, it adds. So everything adds up in terms of having a poor outcome for the child. We did a lot of neurobehavioral outcomes such as this, sensory testing, et cetera, having visual acuity, visual following. That one you have to do your own visual acuity on that one. Reflexes, et cetera. When we looked at the groups along those lines, we also found specific cocaine effects. And you can see that in this case, they only showed up with heavy cocaine use. And so if we hadn't used that meconium, we probably would have not found these effects, because at this age, for those specific kinds of things like attention, head control, reflexes, et cetera, the effects only showed up for heavily exposed babies. One thing we did find was that cocaine-exposed babies, there was a lot of discussion about them being jittery, that they had 4 times the level of jitteriness that occurred in the control group. And our control group was not a normal control group by any means. As you saw, they were exposed to alcohol, tobacco, marijuana, and did not have a whole lot of good prenatal care themselves. We did, this is kind of an early neonatal version of the Fagan test, which we looked at. Babies have a preference to look at face-like forms, and we found that there were deficits in the heavily exposed babies in the first month of life in terms of their ability to orient to these forms and fixate on them. We also, this is an old version of the Fagan test, we did that at 6 and 12 months. And this is you can see the publications are listed for you. Some of them are mine and some of them are my colleagues. At 6 months, when we did this at 6 months, there's a novelty score that's kind of like an overall assessment of how well the baby is visually recognizing and discriminating visual pictures like those that you saw there. And you can see that the cocaine-exposed children start out doing poorly, but that's not significantly different. But by 12 months, at the 12 months time point, they're significantly lower than the non-exposed children. So one of the highlights of our study is that we enrolled about 400 children. At 4 years and at 9 years, we have about 376. We have 376 children at the 4-year time period and 371 at the 9-year time period, and that they represent 93% of the enrolled survivors, which is very, very high. If you look at any of the other studies, there's only one, I think, that really has this high level of retention, which is very important because you always lose people in a kind of a systematic biased way, and you don't know what it is. When we looked at WPPSI, which is the standardized kind of intelligence test at 4 years, we found significant differences among between the cocaine-exposed, heavily exposed. For both groups, heavy and light, we found differences in vocabulary. We found differences for heavily exposed children in the information subtest, and as well in the arithmetic subtest. And the arithmetic subtest was specific for boys only, and that's something also that one needs to think about. Often exposures or effects may be in only one gender versus the other. The other one that I don't have a slide for is that the most significant thing we found was that they had a very hard time on the object assembly task, which is the puzzle task. And it was really at a dose-response relationship. Those who were most heavily exposed did the worst. Those who were lightly exposed did somewhat less well than those who were non-exposed. And it was a very large effect size, and it relates to what I think we're seeing all through. We saw attentional difficulties to begin with. We see the visual recognition difficulties at 1 year of age, and now at 4 years, we're seeing deficits on tests, one which is generalized kind of language, but the other is related to the perceptual reasoning of the children. And that's not total IQ. That's not related to specifically IQ. It's one of the aspects of cognition that's important to think about, and it's what you think about when you think about learning disabilities. Julia Nolan did this study on the continuous performance test, which is a attentional task. Her paper is written in there, and you can see when she controlled for everything else, she found actually that there was a cocaine exposure and a cigarette exposure interaction, so that it was actually worsened by the fact that both substances were prenatally exposed to. Barbara Lewis, these are her language scores at 4 years. We found that cocaine-exposed children did more poorly on expressive language, especially in the area of basic concepts. And she has a study that's going to be coming out soon in pediatrics, which is a longitudinal study of language. Her findings replicated those that Emily Banstra did in Gainesville. So we have quite convincing data that these children have language problems that cannot be attributed to any of those other factors that we discussed. And here's the arithmetic test, which just shows that that the deficits occur only in males. Teresa Linares did this study that was published at 6 years of age, asking the children to report on themselves. They reported themselves as having more oppositional defiant disorder and more attentional problems. And so one of the things is that all of the data that we're seeing in terms of the attentional difficulties and the children themselves having this difficulty in terms of their interactions and control of themselves relates to all the theories that we know in terms of the regulatory system set up prenatally. We did a neuroimaging study, which has just been published, and a lot of people here, Jonathan Lewin in particular, was involved with us in doing the study. And we took a subsample of children and we looked at their brains, and we couldn't take everybody because it's very expensive to do, but we took children who had IQs over 80, who were matched in handedness and gender and all kinds of other things. And what we found was that the cocaine-exposed children had smaller areas of the corpus callosum. And the corpus callosum has also been identified in alcohol studies as very much affected, as being thinner and smaller. And of course, that's the piece that connects the two sides of the brain. We found that also the left occipital gray lobe matter and right parietal matter was also negatively affected. So, and this was not related to their weight or height or anything. We looked at that. This was specifically related to brain development. And this is a model that just shows you the surface area of the corpus callosum controlling for the other drugs, that even when we control for the other drugs, you still get an effect of cocaine. At 9 years, this is I think, very interesting and very important. What we're finding if we control for everything, and if we just look at cocaine-exposed and non-exposed children, who were our original groups, we find this perceptual reasoning IQ is what's affected. That is specific to cocaine. But what we found is that as we look at the other drugs, many of the other drugs are affecting the other outcomes, and I'm going to show you those. These don't show any cocaine differences, but one of the things that shows up is that alcohol is affecting the working memory IQ, which has been found by Streiskuth and Jacobson and others in their other studies. But as a summary of what we've got so far, you can see we have birth effects, neonatal effects in areas of visual attention, language and attention at 1 year. I didn't show you those data, but our 1 year data show that the language difficulties can be picked up that early. At 2 years, we have a study that shows the mental development index is negatively affected. At 4 years, I showed you the object assembly and the arithmetic. At 6 years, one of the things I want to go into now is that we found that we had 42 children who were placed in foster or adoptive care, primarily at birth. Most of them were placed there at birth, and we had to subdivide the groups into those children who were in their biologic mother's care or a biologic relative's care, versus those who were put in a foster care or an adoptive care home outside their own family. And what we found was, these are some more of the cocaine effects. What we found was, if you look at the groups based on, let's say this is the IQ, we'll just look at the IQ. Those 42 cocaine-exposed children who were placed in adoptive or foster care actually have the highest IQ scores. Those who are in biologic relative care have the lowest, and those who are in the control group are about the same as those in foster or adoptive care. And the reason I show you this is because you have to look at all of the environmental factors in order to find the teratogenic effects. Because what happens is when we look at our adoptive care parents, we found that they had better home environments. The mothers had much higher IQs as a mean. They had less depression. And yet 64% of these children, it was significant, were in the heavily exposed category, which makes sense. Those mothers who were the heaviest users who couldn't take care of their kids gave them up. And we're also finding, we had Suchi Nelson, who's a professor in the School of Dentistry, at 4 years 2 and 4 years took blood lead levels of our children. And what we're finding is that these children who are in adoptive foster care families also have significantly lower lead levels. So that we have to look at that and control for that. And when we look at the effects of drugs at 9 years of age, we can identify specifically cocaine on the perceptual reasoning and the matrix reasoning of the standard IQ tests. We find alcohol effects, apart from the cocaine effects, after controlling for cocaine effects, on vocabulary, working memory, digit span, letter number sequence, and object assembly. We found marijuana effects on the coding, and we found our most profound effects based on lead levels. The higher the lead level in the child, the more likely they were to have problems in these areas: verbal comprehension, reading, math problems, etc. And as we look at our children, we can't pull out whether it's the lower lead levels in these parents' homes or the stimulation. I mean, at this point, we can't differentiate it. But independent of all those factors, you still get the cocaine effects. And so I think we're beginning to piece together some of the puzzle of what kinds of domains might be affected by specific drugs. And what's also interesting is that the alcohol effects, which really surprised me, were exactly what Streiskuth has found and Jacobson has found, and they kind of show up. And what happens is that for most of the children in our cocaine group in our study, they have all of those effects because their mothers didn't just use cocaine, their mothers used high levels of alcohol, high levels of marijuana, and these children who were not adopted ended up having higher lead levels There's a significant percentage of them that really have higher lead levels in what's considered the toxic range. And it also demonstrates a failure of our medical care system in that we know lead has this negative effect. All of our children were screened because they're supposed to be in a registry, and this should have been taken care of. But obviously, somewhere along the line, we're not able to do what we need to do. So that, even if we can stop, these are preventable, all of these are preventable causes of cognitive deficits in children. And as a society, we must address them, especially for children who are in poor economic circumstances and who, for many of them, getting them over the line so that they don't fall into the line of mental retardation, something like exposure to lead or a prenatal drug can do this to them. So I'm going to stop there. I think we're done. And if you have any questions, I'm happy to answer any questions. Is that okay?
Yeah. Well, what a fabulous talk. I'm Patricia Princehouse. I'm co-director of the College Scholars Program who sponsored this talk today. Before we go over to questions, I just want to invite you all down the hallway where we'll have a little reception afterwards. So I just didn't want people to get away without that. And to remind you that this is being webcast and it'll be archived, so you want to send your friends to look at it, they'll be able to. And
on my website.
yeah, there you go. And for those who want to know a little more about the College Scholars Program, it's a multi-year program that students apply for in their freshman year. So if you're a freshman and you're interested, please talk to us about applying. We have another exceptional talk coming in the spring on March 6th, Eric Foner talking about the meaning of American freedom. And anyway, we will get on with the questions, and that was just terrific. What a wonderful study.
I hope all of you young people will think about what you're eating and drinking before you get pregnant. Any questions? Yes.
Sorry. I know that you mentioned Prozac as a possible drug that we don't know enough about yet, and so we should be careful about our use of it. Is there any other drug that you find personally suspect and that you think in the future might become a problem?
Well, I know my colleague Julia Nolan is very interested in looking at Ritalin now. One of the things I didn't say is there's a study, one of the latest, you're probably all aware that there's a large methamphetamine epidemic going on in this country. And there is a study being conducted, a multi-site study on methamphetamine, which I think is a much worse drug than cocaine even. So, we don't know about Ritalin, how many people, young women now are on Ritalin that may have children, what the recommendations are. There are all kinds of drugs, new anti-epileptic drugs that haven't been studied or that recently have been studied and have been shown to be toxic. So that's one I think of. I mean, every time a new drug comes up, I wonder. One of the interesting things, a study that I would love to do is when we did our anonymous screen in the hospital in 1990 of mothers, which doesn't identify who they are, we found that 4%, or I think it was 7% of the births were affected by Valium-type drugs. And those are completely contraindicated during pregnancy and labor. And the social class background, et cetera, was different from this subgroup. So that's another drug I wonder about, those kinds, which we don't have any studies on. This is a great field. It's really just a field that is, the methodology has just been recently been developed, and we're beginning to understand how to do these kinds of studies. Yes.
Are you able to speak at all about the clinical significance of any of this? Like statistically, you said there's a big difference with regards to cocaine, perceptual functioning, anything like that. Do these 9-year-olds pass first grade when the other ones, is there anything that you're able to say clinically? Can you tell this is, a child who is exposed to cocaine, this is a child who is not? More than just the numbers.
Well, I think there's so many causes of the same disabilities. There's, I think a lot of these effects occur through a common pathway that multiple things could affect them to begin with. So you don't know. I mean, you can't specifically say it's to a drug, but most of these children and the parents who adopt them will tell you that they're having trouble in school. They're having difficulties. They're, especially attentional disorders. In the preschool years, many of our children were on Ritalin. We had one child who was extremely hyperactive, and the mother said, well, you should see her when she's not taking her medication. So I think clinically there are quite a few effects that occur, and especially when you're seeing the multiple effects of these drugs and the low IQs to begin with. We're not talking about children that have a mean IQ of 100 as a group. We're talking about children with lower IQs plus these very specific problems. Yes? Oh.
That's a hugely impressive data set. I'm very impressed with it. And
Thank you. This is one of my professors. I can go back in time.
Too bad you're associate provost. You'd be able to collect even more data. I have a couple questions. One thing that impressed me is the rather small size of the differences between the two subject sets. Mm-hmm. The other that I'd like to hear you address is, as you know, in the field, one of the major debates is over SES and factoring out SES and whether these deficits really exist at all. For instance, in lead exposure and so forth. And just like to hear your opinion on those issues.
Well, the small differences, as you know, we're talking about groups, and so the differences. One of the things we did, which I wish we didn't do, or I wish we had another group, was at the time everyone was pushing so heavily about getting a group that's just as high risk, that has just as much poverty, et cetera, so that you could look at the effects. We didn't expect that we would have this foster care group. What I don't have is a group with as high IQs as the mothers in the foster care group. So in some ways, I think we've minimized the effects in this study, because we can really only tell that difference within that group, and not if you took a group that weren't in, cocaine exposed, but had mothers. We tried to see if we could find a subgroup of that group, but we can't. So I wish we had taken kind of a group of people who didn't use any drugs, who were squeaky or clean, and maybe from the same social class group. I think the differences would be higher. Also, when you're looking at group differences and it doesn't look like it's that high, you've got to think about, one of the things I think that's happened with the foster care child group is at the 4-year paper, if you look at the 4-year paper in JAMA, the lowest group with mental retardation is that foster care group, even though they're the most heavily exposed. But they also have the smallest percentage of kids with an IQ over 100. So I think what the environment has done is push them over that edge so that they're not mentally retarded, because if you're looking at the curves, a couple of points and you've got a bunch of people who are now below a cutoff and maybe classified as mentally retarded, or so that it has that kind of an effect when you look at the population as a whole. The SES issue, we've looked at every way we can. I mean, I think when you take in the vocabulary, the mother's education, the home environment scale, all of which seem to contribute. I mean, if you look at the papers, you'll see that each of those ends up contributing to the child's outcome, and these effects are on top of those. So I think in some ways we've made it almost difficult to pick up. The effects that you're picking up are only after you control for everything else. And for example, something like prenatal care, I'm convinced, or mother's age, I'm convinced is really not having an effect. But it's just because it's so correlated with the drug use. And so we're kind of taking away a lot of the effect from that. This is the most conservative kind of analysis you could do. So I think between depression, vocabulary, nonverbal intelligence, biologic mother's intelligence, current caregivers, and sometimes we find effects of both, the current caregiver's intelligence as well as the biologic mother's on top, independent of each other. So I think we've pulled out most of it that we can. And all of these families were, within that poverty level where they were on Medicaid for the most part. So, yes.
I had a question about the light versus heavy users, where you had women who said they were light users, but their babies, meconium, would suggest that they were heavy users. Do you think that could reflect a difference in the metabolism of the cocaine, that you have people who are in fact light users, but maybe they metabolize more slowly, so the drug's effects are potentiate?
I do. I think that's absolutely one possibility. The other issue is, when we do the light versus heavy, we're not doing it by trimester. We're taking kind of an average of everything. We do things by trimester, but we then average the whole thing in and take the percentiles from that. And that really masks a lot, because with the meconium, you're only getting the last 2 trimesters. You could have had a very heavy user. There's a lot of unreliability in all of it. Very heavy user who stopped in the 2nd trimester, and we wouldn't get anything in the meconium. So, but I think those metabolic differences are critical issues that we really don't understand. I don't understand them and don't have any way of understanding them. So.
No? Okay.
The other thing I wanted to say about some of the effects, Doug, is that we also get the relationship, which I didn't show here. In most of our papers, we report the relationship between the metabolites and the meconium. It's much weaker than that, but there is a relationship. And also, Cynthia Barer has looked at, she took the meconium and developed this method of looking at fatty acid ethyl esters as a measure of alcohol exposure. And she's taken that group and for the first time is getting developmental effects related to a biologic substance like that. So I think there are other, you kind of have to look at the whole picture. Colin, was that you?
Oh,
okay.
I know you have to take a lot of things into consideration when you do these kind of testings, but do you ever consider race as one of them when you're testing IQ, or just as a control period? I don't know.
Sure. But in this case, the race is the same for both groups. 80% of our sample in both groups is of the same race. So that's controlled for.
Okay. And also, I was wondering, what you think on it, but do you believe that caffeine could have these negative effects as well? Because I have read things about how when you're pregnant and caffeine can have negative effects as well. I just want to know what you think about that.
Yeah, I think that they have found, and maybe you can answer this, do you know about caffeine? I think that they have found that caffeine has had relatively few effects. There have been lots of studies of them. I know aspirin, they've shown effects of aspirin, which we don't really have the data on. But I don't know that literature terribly well. Yes?
Very interesting talk. I was wondering if there's, because of some of any of the behavioral problems or and the increase in use of amphetamines nowadays, is there any part of your study that plans to look at future drug use of this cohort, as they get older?
That's a really good question, and that is of great interest, because we know that there are addiction, quote, genes, et cetera, and that there's a heavy genetic component to people becoming addicted to various drugs. And we are very interested in looking at the onset of drug use and what the precipitants of those kinds of behaviors are. And also because we know that children with conduct disorders, attentional disorders, learning disabilities tend to be more likely to use drugs later on.
It seems not just the genetic effect, but also just their environmental exposure
Correct.
in utero is, changed
Correct.
their neuro.
Absolutely. That's one of the
architecture.
thoughts. I don't think we'll be able to get to that answer because we don't have the kind of data to really look at that. But we're hoping to participate. There's an RFA for genetic drug interaction studies now. I was just talking to Mark Adams, and we'd like to look into that because we have such a good sample with so much behavioral data, that can be looked at.
I was curious about the heavy and light use. I mean, I think in terms of people I've known, if you asked them heavy versus light, they would mean completely different things by this. And even if you asked them how often, I don't know how reliable they'd be. How did you determine in interviews what was heavy versus light?
Okay, this is what we did. We interview the mothers. There's a whole method of doing this. It's very carefully done, but any interview method has a high level of unreliability in it. So I think in the end what you get is exposure versus non-exposure and heavy versus light versus none. You end up breaking them down. We ask the mother very detailed by trimester what she remembers. We kind of bring up certain holidays. We ask what's the highest amount you ever use, what's the lowest. There's all kinds of things that kind of go into this. And then what's their typical pattern of use. So I think there's certainly, we don't ask them, were you a light user or were you a heavy user? We ask how many drinks did you drink on that day? Do you remember this holiday? What did you do then? And we have some very heavy users, who kind of were using lots of alcohol all the time that can tell you. So there's an amount of unreliability into it, and a lot of it comes from the skill. You really have to have very skilled interviewers taking the time to probe, to help the mother remember, because who would remember?
Well,
yes.
I guess one more question, and then we'll. Here.
Hi. My question is, now that you have this data, showing these effects that cocaine has, what's the goal? What's the plan to use this data for prevention? And how can we go about working on prevention? I worked last year in a clinic where I worked with a lot of young mothers, City of Cleveland, and I found that we really didn't see a lot of drug-using women because they avoid prenatal care due to the consequences of positive screens. And so I guess my question is, what's the long-range goal of putting this information into community use?
Well, I think for me, and especially even for fetal alcohol syndrome, for example, in England, they're noticing that there's much higher rates of alcohol use among young people. And I don't know if it's the case here, but the meeting I was just at, they described that it's double what it was. I think this whole issue of education and prenatal care, most mothers want to stop using drugs. In many ways, it's great that we don't have this epidemic anymore. We just have the children who were affected, but we're going to have another one, I'm sure, of various kinds. I think we have to have a system of prenatal care that really looks at each individual mother. One of the big barriers is obstetricians who, we've passed a state law that said that you had to screen mothers for alcohol and drug abuse. It's not done here. We don't do it. And the same thing I heard in my study, I heard in England from the doctors there last week, which is, there's supposed to be screening in hospitals. So you're a pregnant woman, you come in, you have a baby, which is a little late, but even then it's still important because you might be breastfeeding or your behavior may be affected. But the nurse comes in or the doctor comes in, and in my research assistant's case, after we had heard how all the screening was being done here, et cetera, she said, well, you know what happens? I just had a baby. The nurse came in, turned her back to me, sat at a desk, and went through this questionnaire and said, well, you don't use any drugs, do you? You don't use any alcohol. We're not screening, and it's because we don't have obstetricians trained to know what to do. In the case of cocaine, people were afraid of lawsuits, which occurred among middle-class families who were identified and then the hospitals became defensive. And it's costly. We have to really change the system of care here. But in the long run, it's going to save a lot more money because these children, you can see the deficits right from birth. And you really need to, when you can prevent that and create, have a whole bunch of children who can contribute to society when they grow up, as opposed to having more problems. So it's really got to come from the medical insurance system and whatever we do in terms of community care. And the treatment of drug addicts. We have a very punitive attitude. I just signed on to a letter that Lynn Paltrow, who runs a organization to protect pregnant addicted women, the answer that a lot of politicians have is jail them or punish people, and that doesn't work. I mean, just putting people in jail for drug addiction is not going to help. So in this case, a foster child who was cocaine exposed apparently was a big problem to the foster parents, and the child was killed, which I didn't hear about. And the response of the government was, we need to jail pregnant addicts. So, I think the whole way we treat drug addiction and the way we teach, I also think we have a kind of leftover from my generation, the boomers from the 70s, a more benign outlook on drugs. And I think probably marijuana is less of a problem than other drugs, but alcohol, most people don't just use marijuana occasionally, et cetera. But there's still effects being found even at lower levels in some of the studies done in Canada among middle-class families. So we have to think about those things in that way. And we've become very, I think, lackadaisical. I think too many young adolescents are using drugs, and there's kind of a permissive attitude about it. So, thanks.
Well, this is just such a great synthesis of so many different kinds of information, and please join me in thanking Lynn for letting us in on it.
Thank you for having me, Patricia.